Well, welcome to this special Academy of Osseointegration 2024 annual meeting. I'm Wes, the dental guy.
And I'm John, the dental guy. And I'll tell you, it's been, as usual, as expected, a great first morning. You know, we always come to this meeting expecting to see new things, and we also kind of get to see where we are in terms of even the old. You know, what should we be doing? And this morning we got to see some very interesting corporate forums. You know, we got to see some new things.
So what's interesting about corporate forums here at the Academy of Osseointegration is that they allow corporations to take a half day or more and really shine their products up and make them look, you know, the greatest and best they could possibly look. They put some high-level speakers on the stage. We got to hear Mark Ludlow just recently. We'll have on the show later on. But also, we've got to ask some questions even about where are we at?
Right.
Because a lot of the stuff we saw was a little bit old, John.
Yes.
You know, some of the stuff was new, but I mean, a lot of the stuff was like, we've been doing that for 10, 15, 20 years.
Right, and that's always the balance, you know, that we try to find, and this Academy, I think, does a great job of trying to find that, which is, you know, there's a lot to be said for the classic way of doing things and understanding, for instance, analog, but then there's also a lot to be said for how that factors into our digital world. And we're really excited because our first interview of this meeting is with somebody I think understands both sides of that. And so we're joined today by Dr. Todd Schoenbaum. Good to have you.
Hello. Thank you for having me.
Welcome to the show.
Thank you, guys. Great to meet you.
Yeah, it's been good to get to talk to you a little bit. And so kind of tell us a little bit about, we understand that you're at the Medical College of Georgia, right? At the dental school there. And tell us a little bit about what you're doing there, and then we're going to dive a little bit into some topics that I know you're going to be presenting tomorrow on some material selection, and then maybe. But give us a little background on what you're all about there.
Yeah. So after 12 years at UCLA, I was looking for more fertile opportunities in the realm of clinical implantology and clinical research, and found the Dental College of Georgia, and it's been going awesome. We're really pushing hard on some really innovative developmental stuff just to improve the quality of care that we do in practice. As you will probably, and the folks that are attending the meeting will see, is that oftentimes what we do, especially around implants, we like to say it's evidence-based, but we're sorely lacking, unfortunately. And we're lacking in funding and understanding and how to do that. And there's challenges with that. So at any rate, I'm the director of clinical research, and I'm also the coordinator for clinical implant education at the college. So I help make sure that our surgical services and the residents in those programs are putting the implants and the type of implants and the size of implants we want and where we want them, and making sure the folks are storing them in HD, GPR, PROS, and the students are restoring them appropriately, and kind of trying to keep everybody on the same page in a big place.
We're going to come back to the research here in a little bit, but and we'll talk a little bit about the importance of research and clinical decision making, and we don't want to discredit that. And I appreciate that, because we're all about Geeks Corner.
That's right.
And Geeks Corner is where we get to geek out about what the research says. But before we get into that, some of the things that you've talked about in the past and what you're here talking about this weekend here at the Academy meeting is this idea of material selection. We've heard a lot about the peri-implant tissue, and in fact, some of the research you'll do, and we'll talk a little bit later on, is about the reaction to peri-implant tissue. We know that, implants don't have a PDL. They have a circumferential fiber, and there's been so many innovations that we've heard about in the past, different companies trying to build some type of peri-implant abutment that the tissue can really interact with and be protective of. What has been your conclusion so far in your breadth of practice about what we should be using coming up out of the implant?
It's a great question, Wes. And I would say that, unfortunately, there's probably no profound realization or innovation in that area. Most of the materials that we've sort of evolved and gravitated towards over time, with whether it's zirconia or titanium mostly these days, mostly they're doing their job pretty well. And, you know, certainly we're always looking for a clinical advantage or a clinical improvement, and manufacturers always looking for a market advantage or market improvement. And the pendulum is sort of swinging back, right? As we sort of, over the past maybe 20 years, the pendulum swung towards roughened, enhanced surfaces all the way up to the implant abutment junction, and now it's sort of swinging back towards smoother surfaces, we'll say. As, we've only been doing implants in its modern two-component titanium form for about 40 years now. This is the 40-year anniversary of the 1983 conference, right? Actually 41. It was 2024. Yeah. So at any rate, I'm not a big, based on the data that I've seen and the preponderance of evidence, it's messy, and usually when the data is messy and doesn't all pile up in one pocket, it sort of tells us that maybe we're not seeing anything profound in that. And I know folks would love to hear that, this is the best way to do it with this, and that's what we should be doing. This is polished, or this has holes the size of fibroblasts, or whatever special thing it may be. But I'm unconvinced.
Yeah, no, I think that's equally important, is to be unconvinced. To know that we don't have some special sauce that we can just say this is it. But maybe we can focus then on just sort of the performance of these materials, maybe mechanically, and also the aesthetic side of it. Because when we're making decisions on, say abutment selection, if we can say, well, we can't make a convincing argument that it's a biological advantage, maybe we need to think, okay, well, what do we use in these difficult situations? And one of the most difficult situations we often talk about is a lateral incisor, a maxillary lateral, where we have oftentimes a small abutment, and we have to do that because of just space limitations. So we're looking for a combination of strength, but then also we care about aesthetics. And so we sometimes struggle in these cases of trying to determine, do we go the route of a zirconia abutment? Do we go the route of a titanium abutment? Do we anodize it? Do we opaque it? And then what type of restorative material are we looking at on top of that? Kind of speak to that a little bit. What's your sort of go-to in some of those situations?
So a single tooth in a relatively small space in the aesthetic zone, patient with a high smile line with high aesthetic considerations. Generally, unfortunately, the anodization, whether it's gold or pink, doesn't work that well. And we measure color change by something called delta E, and I'm not a color scientist, but different folks say there's different thresholds of what's perceptible, but that sort of assumes that everybody's got the same threshold of perception. And we all have patients, and usually the ones missing a single lateral or single central with the high smile line that have delta E perception of like 1, right? And we commonly say you can't say anything less than 4. At any rate, even those zirconia abutments, there's been studies looking at where they take actually a piece of relatively fresh tissue, not human, but relatively fresh tissue that's about the same thickness as most folks' gingiva, so about 3 millimeters, and laid it on different abutment materials. The silver color metals, whether it's cast gold or milled titanium, and the anodized titaniums, whether it's gold or pink, all have delta E's well over 4. And even the zirconia, though, produces a delta E. And there's also a color change related to the typical concavity that's present in the ridge. So it looks darker, and then if we measured it, it might not actually measure quantitatively as dark as we might perceive it, but it's because there's shadowing effect of the defect. Sure. To your consideration about the space and the functional needs, I think you were alluding to, it gets challenging in small spaces. The mouth is a very tough environment, and we've got very tiny pieces of metal and ceramics, and the smaller they get, the weaker they get. But fortunately, most of the milled options of titanium, perhaps we have a milled abutment that has the retention we need to hold the crown on, one of the main jobs of the abutment, and then also has the robustness of something thicker than, say, what's generically typically referred to as a tie base, depending on the manufacturer, which tend to be a little bit weak in maybe a central or canine position, but in a lateral position might be fine. But the milled options are getting better and better. They're getting cheaper and cheaper, and we're probably not too far off from a time when we've got very local options to the practice that can mill very high quality abutments. We can place that margin deep subgingival to minimize the tissue color change and run the crown, the zirconia down all the way to that, and have the lab put them together, right, with commonly referred to as something like a screw-mentable restoration, if the angulation allows it. And then also the angled screw channel options, which in my opinion, and we don't have data on this yet, honestly, and we're figuring it out now, but the initial iterations of most of the angled screw channels are going to be problematic because the abutments are too small, and the palatal wall especially is too small, and we're going to have a lot of debonding of those things.
Yeah, we were just discussing this, and I appreciate the type of restoration you're describing because it builds into us this idea of decreasing the chance of some type of a revision. And we know that implants are not for life. And we used to say that 20 years ago. I can remember coming out of residency and I'm saying, oh, you can place this implant and it's in for life. But most likely there's going to be some type of revision. And how young and dumb were we, right? And now you're building in some prosthetic revision with this type of design. We're driving that zirconia down. And because of milling technology, and milling is becoming strategy-wise a little easier to learn from a technician standpoint, the laboratory per se, we can ask for something that's a little more robust than some of our stock abutments and really start to build in some choice of where we do want that margin to change from titanium to zirconia, or how about lithium disilicate?
Yep. Totally viable option. For me in clinical practice, honestly, I leave that decision to my technician. For most scenarios that are not overly demanding functionally. Obviously we'd switch to something like monolithic zirconia in more demanding cases, but in the aesthetic zone, if my technician tells me he can get a better outcome with EMAX or lithium disilicate or lithium monosilicate or whatever, fine. And if he says or she says that they can do better with layered zirconia, I'm all
well, before we get away from the abutments, though, just on because I want to talk about also some other restorative materials. You mentioned, tie bases compared to, say, a milled component. Should we be using tie bases? Do you think there's a place for those when we have customized milled abutments that have a similar, say, emergence profile?
Yeah. The great thing about tie bases, they're cheap and they're easy for the lab to work with. The downside to them is the walls are generally too thin for demanding scenarios, whatever that may be, and they're typically a very polished metal, and they typically have very minimal retentive features. I was just chatting with Vincent Femmer from Geneva yesterday, who's a technician, master dental technician there at the University of Geneva, and we were talking about just that, how the tie bases should look like temporary abutments.
That's right.
But they don't, because then the technician has to cut it down and scan it back in. But we are getting to a point where we have more robust in-office options or small-scale laboratory options for milling or printing, and those options are going to continue to improve. The rationale for using a stock component over using a ideally patient-centered or site-specific milled option is convenience and a couple bucks.
That's right.
Yeah.
Yeah, patient-specific abutments, customized abutments. I think, John, it's one of these not new things that you and I've had access to, thank goodness, and you as well, Todd, I'm sure, because we're working with people that have this technology and the ability. And if you're listening to this and you're thinking like, well, how do I know if my laboratory can do these things? It's worthy of a conversation. And we've had opportunity to talk to Bob Winter over the years, and he always says you're always practicing to some limitation, and your limitation might be the technician you're working with, and that's okay.
Yeah,
that's okay. It's understanding the limitation of these parts and pieces in small spaces, and then learning what the disadvantage is and what the advantage is of moving out of this.
But what's interesting, I think, and we've seen this even this morning in the corporate forums, is we have manufacturers changing connections oftentimes. Every few years, we can talk about why off the camera, but there's changes in connections, and sometimes we think, oh, that's wonderful, and other times it's frustrating. But as a laboratory, for instance, when you want to be able to mill custom parts, there sometimes are not great options, especially as a small laboratory. You alluded to this earlier. If you've got your mill set up for zirconia and then you want to mill a titanium abutment, that's a tremendous problem unless you want to have, again, big capital investments as a laboratory. So I think the labs, we saw at corporate forums today, a lot of people using tie bases in situations where we look at the height and we're going, that will debond, and we're seeing it on the screen, and so I think that it's interesting to think, from a laboratory standpoint, they're faced with decisions. They have to either invest in some of these things or the clinician has to invest in some of these things, because it seems like we can do better in some cases than just the tie base.
And I think I did a poor job answering your question about the tie bases. I think that they are probably fine for very low demanding situations. So
Right.
Single premolar and an otherwise normal arch,
Yep.
maybe a lateral incisor.
Mm-hmm.
But anything else, I would have a hard time understanding why a custom milled option would not be superior.
Research is something that you're very passionate about, being the director of clinical research at the Medical College of Georgia, correct?
Right.
This is near and dear to our heart. Journals are always on our desk, and we love understanding that aspect of dentistry because it helps build our decision-making capacity. We shouldn't be just using clinical experience and this works in my hands, and it's a combination of case logs and things you've done over the years, and then building that and looking at what multi-center trials, what randomized controlled clinical studies have shown, and really case cohorts and look backs and all the things that go in. You're developing research projects. You're advising people at the university there on how to build a good research project. Let's call it that. Let's just go back to the science fair that we all grew up around.
That's right.
And I mean, that's near and dear to my heart.
And
now.
I remember talking to Steve Eckert years ago about this because, of course, he's super passionate about the whole idea of how to create a publication that means something and has impact factor and all these other things we talk about. But you were just before we began kind of talking about a study that you guys are kind of kicking off that I think checks a lot of those boxes. So tell us a little bit about what's going on there, maybe a little bit about some trials that you guys are working on where you are.
Sure, John. So actually we're now the Dental College of Georgia.
To
the dismay of many of our alumni, we went through 5 name changes, but this one seems to be sticking, so we're pretty happy with that. Actually, in October, we just got a very sizable grant from the NIDCR, which is the dental craniofacial wing of the NIH. We got a very sizable 5-year grant for developing clinical research at the Dental College. So big picture, my hope is that in 5 years when we sit down and talk again, we'll be talking about all the amazing stuff that's coming out of the Dental College of Georgia. We're building a very robust culture of clinical research. Clinicians, my dad was in private practice, solo private practice for 47 years. Although I'm an academic, I very much appreciate and understand the world of the private practice. And I feel like we've got a very big divide to the point where if you say the word research to a clinician, we sort of freeze up a little bit. Like, you're going to start talking about cytokines, and I don't understand cytokines. I don't want to talk about cytokines. I want you to teach me how to do the latest bone graft procedure. And this is what works in that person's hands. And that is a very valuable part of our decision-making process. Sure. And research is not there to negate that. Research is there to complement that and to steer us, perhaps, in better directions. For folks that are still in their training programs or have recently completed their training programs, oftentimes I'll hear them tell patients that implants are 98% successful as we try and sell it to them. First, there's no agreed upon success metric. Your level of what is success in your practice might be a much higher bar than what's in my practice. And therefore, I would have a higher success rate, right, even though I'm performing more poorly. But also, when we're learning to do things, this is an operational profession where performance matters. That is something that develops and gets better over time with increased training, with increased understanding of the science behind it, and our expectations of success or even survival of implants is typically overestimated and overstated. If you remember when the COVID vaccines first came out, there was talks about effectiveness studies and efficacy studies, or phase 1, phase 2, phase 3. And in dentistry, what we oftentimes see is an expert in a very highly controlled environment that knows they're being watched, with an industry partner that knows they're being watched, with patients that know they're being watched. And so what do you get? You get a very skewed, optimistic outcome.
Bias.
That's right. And we typically call this performance bias or observer bias, and then if it doesn't come out well, that stuff tends to disappear in our profession. And then we have a publication bias problem where the only people telling me how great implants are the people that are really great at implants.
Yeah.
And as a profession, we're actually in the stage of implants where we're sort of, as you were alluding to, Wes, kind of dialing back our expectations amongst ourselves and the public and our patients, right? Where it's like, hey, implants are great, but they require revision, replacement, repair over time, like anything we own, right? And the mouth is a tough environment.
Yeah.
So, but long story short, yes, we are going to be doing some very cool stuff at the Dental College of Georgia in clinical research. We actually are expanding our annual research day to be a Southeastern event. So we're going to be inviting aspiring clinician scholars, clinician scientists from all over the greater Southeast to come and collaborate and share their work with the profession. We'll be publishing all the abstracts from the entire symposium in my journal. And then the study you were asking about, this is a developmental study, which means we're exploring the possibility of this being something useful. The impact of the information we come out of this might steer us towards something that will be profound on the profession. Our theory, there is some data to suggest in the dental and the medical literature that the level of inflammatory agents, or we call them cytokines, but inflammatory stuff in the body, we each have different levels of these various things. And there is some data to suggest that some of those might be tied to increased levels of bone loss around our implants or increased failure rates. So perhaps those patients that we have that have an implant that works great for 20 years and then suddenly the bone collapses around it, or the implant just overtly fails suddenly after being great for 20 years. Perhaps something changed systemically for them, and perhaps that's something we could catch in a simple saliva test that could be run inexpensively. Hopefully in 5 years, what we're talking about is a new development where you and I have patients spit in a cup, maybe in the office, maybe next day, something that goes off, relatively inexpensive analysis of the saliva, and we could determine whether or not the patient is high, medium, or low risk for implant problems, we'll call it.
Sure.
So like for example, we typically will ask a patient to get their latest A1C if they're diabetic. Well, it might be nice if we had the latest IL-6 or TNF-alpha level on them, and we'd know, hey, this one's coming back in the red.
Yes.
Right? Like maybe you don't want me to do an implant for you because you're at a high risk for a problem. Maybe we should try something traditional and non-surgical.
Yeah.
Potentially.
Well, everything's great until it is not.
Yes.
And, that's implant dentistry. And when it goes south in a big way.
Well, and everybody's asking the question of and has been for many years on what is the reason for failures and late failures. The early failures, I think we have a somewhat decent handle on, or better handle on, but the late failure has been a little bit of a mystery.
It's frustrating because, we can talk about cases where we go year after year tracking mean marginal bone levels, and then at the 5-year mark, all of a sudden, what? Is this an idea that, we have a rejection of an implant, right? It's a foreign body. And is there something that's going on in this patient? Bone is dynamic. It's not static. But also the body is dynamic, and it's changing. And as we develop protocols, we've been asking for this for a long time, Todd. As practicing clinicians ourselves, and and your dad, we want something that's easy.
Well, and you think about this with regard to even perio risk. That's been a similar discussion. Is could we find a way to determine people's periodontal risk based upon some of these same factors? Could we do salivary testing? And I think there's been some salivary testing developed, for periodontal disease, for instance. And so then, we've looked at CTX testing to try to figure, this is years ago, again, with Marks and his group on, can we predict osteonecrosis risk? Anyway, I think, so your thought process, though, imagine in the design of this, that you've got to be very careful to try to control for a lot of variables in a case like that. So what are some of the strategies as you're kind of thinking through a study design like that you shared some of this earlier with us to try to, control for some of the things people are going to start asking you about that?
Right. Well, so our co-investigators, so we have three investigators at the Dental College of Georgia, Marshall Newman, Mir Ghali, who respectively run the oral surgery and the perio program. We'll be adding one that is going to be the director of the PROS program. And then co-investigators Carlo Ercoli up at Eastman, and Tara Agaloo, past president of the AO, is our site investigator at UCLA oral surgery. So to your question, though, calibration amongst different operators, right? It's tough. There's different method. Everyone's got their own bone graft concoction and all that. So, but basically the way we handle is an inclusion-exclusion criteria. These types of patients are allowed. These types of sites are allowed. These types of implants are allowed. And that's the box that we put everyone in. But some of the finer tuning, for example, maybe you use brand new drills every 5 osteotomies and the other investigator replaces them only when the bone's smoking, right? And controlling for every variable is not feasible, and nor is it actually desirable. because let's say I said, okay, we're going to have to replace the drills for every osteotomy. Well, now the data I've gotten out of this study is not relevant to your practice.
It's true.
Right?
Exactly.
Because so things like you're asking about, like, what about like crestal depth? Are we controlling that? We're not. We'll be all using like a 2-piece titanium bone level type of implant, but at the discretion of the operators, and the needs of that specific site.
Which is a more real world, I would think, way of being able to apply that data, because, again, like you say, sometimes if you control things so much, you realize that's not the real world. Yeah. And so you have to have it application.
We have a huge problem with this in implant dentistry because it is a device-specific discipline, which means, okay, let's say I show you my study about, the platform switch saved me 0.2 of a millimeter of bone loss from the IAJ at 10 years. And you go, well, I've got a platform switch implant. I'm going to get the same results, but maybe yours is switched more or switched less, or mine's polished and yours is rough, or whatever it may be. So extrapolating the science can be a little bit hard for us too. And, my view is that those of us that are clinically oriented academics, our job is to discover the information, digest it, make it understandable and clinically relevant. Because the folks that are in practice, their job is to take care of patients. That you do not have the time and resources to deal with all that stuff, but the academic folks, their job is to digest it, come to the AO, and share that information.
I think bringing this full circle, this is where we have to really come together. People like you, and saying what you just said, is being able to take clinical research, put it into a format that is easily understood. And we're not just talking about cytokines here. We're talking about real-world things. Yes, cytokines might be a part of that, but how are we communicating that? This is the importance of a group like the Academy of Osseointegration, and having a quality journal like, like
JOMI or IJPRD. Or there's a million of excellent journals that are putting this out there.
But your dad's sitting there in the chair next to you right now, 45 years in practice, and you said the disconnect has widened. We have a problem.
Yeah.
What are we going to do to bring it back to where we are connected to research? Because we see a lot of problems right now with people just doing stuff because they saw it somewhere.
Right. And unbeknownst to most of us in our profession, most new devices brought to market for dentistry, like implants, are no longer required to have 3-year clinical data on them. Which means all the latest and greatest stuff you see that says...
Because they're using predicates.
That's right. They use a 510K device mechanism to bring it to market. So,
you listen to this. Did you know that? Do people really know that they're using devices that have not seen 3-year clinical trials on that device?
That's right.
You need to ask your reps, show me the 3-year clinical trial.
That's right.
Well,
That's true.
What we really need... So the good thing is it brings a lot more innovation to the profession. Right,
True.
because it costs a lot less to bring it to market. The downside is
we're doing the research.
We're doing the beta testing, or even the alpha testing in some cases. And to your question though about how are we going to fix this? We need funding for research. Research costs money and resources. We don't have a lot of funding in dentistry for things that we would recognize as clinical dentistry. For example, we need to find the NIH has a certain pot of money for dental craniofacial. They're going to spend it on, honestly, more significant things, right? Like cancer, right? Salivary testing for really widespread, endemic, systemic problems like diabetes. So that leaves basically foundations like the AO Titanium Foundation, like the AMIS Foundation, like the AAP Foundation, the ECP Foundation. All those ones, they need to step up and fund clinical research. Industry needs to step up and fund more clinical research. And it needs to be done by folks that are involved in clinical practice as well. So, so the NIDCR is actually shifting that way some. So this recent UO1 mechanism that they put $7 million into in the first year, which not a lot, but it's sizable for clinical dentistry. So we need folks that understand the research, that help develop the innovations in clinical stuff, that test the things that the manufacturers bring to us and say, here's the latest and greatest. And we need that testing done ASAP because clinicians are today faced with a choice for their patients. Should I do X or Y?
That's right.
And unfortunately, that puts a big burden on the financial and goodwill of the practice. if things go sideways.
That's right.
And you can look back through class action lawsuits about things that have gone sideways for folks. And, people have had their practices ruined because something didn't work out.
That's right.
Yeah,
well,
recalls for a small business is a big deal.
Yeah, and
It's
I
a
think
big
that's
deal.
where, we've always said that as, clinicians, we've got to be demanding that, in a positive way. But, like you say, to our reps, to our companies, we need to be saying, hey, where is the data? And we want to see that, because I think it has to filter back up if we accept, lowest common denominator. That's what we're going to continue to get. Right. And I think if we say no, we expect more, then hopefully that filters back up, and we just have to expect more. And I think that's it's exciting to hear that that's what you're pushing forward on, and that the funding is starting to change, because that's been a big problem.
It is.
Todd, as we finish this up, we've asked this question many times to people that have been on our show. What is the thing that most excites you about where we're at right now and what we're going to do going forward? I stumped him.
Well, I would say, for me, it is the thing that we were just talking about. It is this sort of, hopefully, it's going to be slow, and maybe it's a career-long goal of mine, that somehow we get research to not be a dirty word in dentistry, and we get our folks that are doing the research and digesting the research and translating the research into clinical applications, that they are more well-versed in what the clinicians need and what the clinicians do and do not understand, and the clinicians are better trained, hopefully, like the training we're doing. We're starting a master's program at the Dental College of Georgia for clinical research, that we have clinicians that are better trained in digesting the things that people tell them, making us have treatments in our practice that are less problematic, right? I mean, ultimately, at the service of our patients and at the service of our populations, that we are doing a better job, that we perform at a higher level. And that's
in the end, that's how it translates back, right? Is that we actually get more success in our individual practices as a result. We should want this, not just because it's better, but because we on Monday morning we need to be able to make the right decision, and that's going to help us to have less complications, less issues, be more profitable. All of the above happens.
And we should, both in the clinical research side and in the clinical side, we should be less tolerant of mediocrity. Because so often we say, I've been doing it this way. It works pretty good. It works, and we have a failure rate or a complication rate that we understand and we accept and we know, or whatever it may be. So,
well, Todd, this has been a pleasure.
Oh yeah,
research is not a dirty word, and we could just keep going on.
Yeah,
he's a man after our own heart, John, because this is True Geeks Corner, and with Todd Schoenbaum.
Yeah, exactly.
From College of Georgia.
So
Dental College of Georgia.
That's right, Dental College of Georgia. That's right. I got to remember. Well, thanks for being with us. And if you've been listening to this and you have been challenged, hopefully you have. We just would say, go back to your reps, go to your companies, go talk with your colleagues. How can we contribute to making things better so that we can not accept or tolerate mediocrity? I love it. So we'll be bringing lots more great content to you guys in the next coming couple of days. Even if you're seeing this a couple months from now, you're going to be wishing you were here, right? So we'll be back with more interviews just coming right up. So for Wes, I'm John, and we are the Dental Guys.